Today's topic is going to be federal, legislative and prescription changes that you need to know. And new and upcoming changes are coming to Medicare, and traditional health insurance coverage and benefits may affect your treatment. Additionally, the cost of healthcare services and how you access them may be changing. And Diane is here to review those changes with us today and help us understand what's coming in the future so that we can be better prepared as a myeloma community. Diahanna is the financial program manager who specializes in financial help for multiple myeloma and AML patients. As a professional financial consultant or advisor, and former caregiver of her husband who was diagnosed with multiple myeloma, Diahanna perfectly understands the financial issues facing multiple myeloma patients and other cancer patients as well. With that being said, Diahanna, thank you for being here today, and we look forward to your presentation. Oh, I think you're muted, Diahanna.
That might help.
Okay, I was like, is she here? There you are.
Thanks, and as usual, everything flows off your tongue so effortlessly. This is going to be a very, very complicated, and we're going to go through it rather fast because I would like to have opportunity for you to speak or ask questions at the end. And one thing I need everybody to understand that all these changes are not in effect now. They are going to be over a period of time. And hopefully, if there's another administration that comes in, those things will not go back. So this is what we're going to go through. The federal administrative changes that will impact your wallet, understand how drugs are priced, very important. Changes to prescription costs that are going to be going forward over the next 5, 6, 7, 10 years. Hopefully it'll go on forever and even get better. Options for expense coverage, preparing for changes, and talking to your healthcare team. Next slide. So this is something a lot of people don't understand how drugs are priced in the United States, and it's really frightening to think we have the best. We consider ourselves the best healthcare system, and when you really are in the healthcare system, you realize just how flawed it is. But drug companies' pricing is relatively unregulated. Consequently, they often raise costs beyond inflation prices, and we know inflation today is unbelievable. This leads to drug companies increasing revenues continually, even if the demand for one or more drugs is not high. That is the way they make money. In a recession or inflationary periods, drug companies do not lose money. When pricing a drug, pharmaceutical companies consider the following things: cost of the research and development, the competition that's out there, and that's why they try to keep people from coming in and doing biosimilars very often, because they can price those brand name drugs. The drug uniqueness, how effective it is as well. The ultimate goal of pharmaceutical companies when pricing drugs is to generate the most revenue. That is the key thing to understand when you're going to the pharmacy to pick up your drugs. We're going to go through Medicare quite a bit here because this is the area that's going to be really most impacted by these changes. So let's go through this. There's a deductible stage. It's $505 in 2003 that you must pay before insurance begins to do anything. And that's very much like your insurance deductible. You're responsible for 100% of your prescription costs out of pocket until that $505 is met. Very much like deductibles, like I said, and requirements in health insurance. The initial coverage stage, after you did that $505, the amount of your co-payments and co-insurance now comes into play. So you'll pay your share of your prescription cost according to your prescription plan. And then the Part Plan D that you have will pay for the rest. Now, remember, when you pick up your Part D plan, that is a standalone plan under your Medicare program. If the combined amount you and your drug plan pay for your prescription reaches $4,660 in 2023, and some of you may have already met that if you have these high cost of insurance of prescriptions, then you will enter the Part D coverage gap. Now, this coverage gap is going to be very interesting because it's going to go into the catastrophic phase.
Diahanna, sorry to interrupt you. Do you have your microphone close to you? It's kind of hard to hear.
Is this any better?
I'm not sure. We'll see with the audience.
I can always put the headphones on if that makes it easier.
Okay.
I'll do that. Just give me just 1 second.
Yep, that's fine. We'll try that.
All right. Let's see. Okay. Okay, is this any better? Audrey, can you hear? Is this any better?
Yeah, I'll wait for our audience to tell us. Did you make sure that it's connected to the, here, we'll stop sharing. Did you make sure that it's connected to your earphones? So when you click the arrow by your microphone, did you select the earphones?
I've never had to select the earphones. It usually automatically does that.
Okay. If our audience could give us feedback on how well they're able to hear, that would be helpful to me. Okay, I think
So shall
there's
I,
been no change since you put them on. I don't think it connected to them, but
so no change.
it's okay. Let's just keep going. You will receive a recording of this, and just make sure your computer audios are as high as they can go. I'm not sure what's happening. Thanks for your feedback, everyone.
Okay, so the initial coverage stage, the amount of co-payments and co-insurance will come into play after you've paid that $505 in 2023. You'll pay just your share of the prescription costs according to your plan, and then a plan will pick up the rest. If the combined amount you and your drug plan pay for the prescription reaches $4,660 in this year, you will then enter Part D coverage gap. Now, I've spoken to a lot of patients so far this year. Now, a lot of those people go in the first 1 or 2 months, they are now in that Part D coverage gap, which can be quite frightening. So let's go on and see how this Part D coverage gap goes. This is part 3. This is that scary, frightening donut hole. And this is supposed to be going away slowly but surely. This means there is a temporary limit on the amount the drug plan will pay for your covered drugs. Not everyone will enter the coverage gap. It doesn't apply to members who get extra help to pay for their Part D costs, so they don't have to worry about it. Once you are in that coverage gap, you will not have to pay more than 25% of the cost for your brand name and your generic prescription drugs covered by Part D plan. That's biosimilars and the like. And the full cost of these drugs will be used to move you closer to the catastrophic phase. In addition to other things that we're going to point out later, it's going to get you closer to that catastrophic phase, which means you'll pay even less. In 2023, once you've spent $7,400 out of pocket, that you've paid out of pocket, you're out of the coverage gap and now into the catastrophic phase. Some people wish they get in there sooner than later, because then they're for the rest of the year, they're going to be paying a less amount for their prescription cost out of pocket. Next slide. So what counts towards your coverage gap? That's your phase 3. Your yearly deductible, your co-insurance, and your co-payments. The discount you get on brand name drugs in the coverage gap, and what you pay in the coverage gap. All of that, it counts towards your coverage gap. So it moves you closer to the catastrophic phase. What does not count in that coverage gap? Your drug plan premiums, the pharmacy dispensing fees, and what you pay for drugs that are not covered by your particular plan. Anything that's not covered by your plan is outside of anything that's going to be happening with you. The next slide. So the catastrophic phase. In this phase, you'll pay only a small co-insurance amount or co-payment for the covered drugs, very important to point that out, for the rest of the plan year. So in 2025, remember, this is 2023, there's time before a lot of these changes come into place. There will be a new manufacturer discount program in Medicare. Now, this new program will require drug manufacturers to pay discounts on certain brand name drugs and other types of drugs called biologics and biosimilars. Biosimilars are generics. Both in the initial coverage phase, it is in the initial coverage phase, it's going to be 10%, and in the catastrophic phase, and there's a 25% discount in that phase on your brand names, biologics, and biosimilar drugs. Next slide. So in 2025, there will be a new manufacturer discount program in Medicare that we just covered. The new program will require the 10% and the 20%, but in addition, government reinsurance in the catastrophic phase will decrease from 80% to 20% for most name brand drugs, biologicals and biosimilars, and decrease from 80% to 40% for generics. Currently, Medicare pays 80% of the drug spending incurred by Part D enrollees with drug spending above the catastrophic coverage threshold. So with all of these changes coming into play, you should see a overall less out of pocket that you're going to have to pay because of these requirements. And for the high cost drugs, there may be some Medicare will now be negotiating prices on some of those drugs. Next slide. So here's the timeline for that prescription drug provision in the Inflation Reduction Act of 2023. It requires drug companies to pay rebates if drugs price rise faster than inflation. Well, that's kind of questionable because right now inflation for drugs to rise, for there to be a rebate on that is kind of high because the inflation rate is extremely high. That means the drug prices have to rise a lot higher than they are right now. Limit installation cost sharing to $35 per month in Part D and Part D, Part B and Part D. So if you're in, it's given to you in hospital or doctor's office versus when you buy it from a pharmacy. It reduces cost and improves coverage for adult vaccines in Part D, Medicaid, and CHIP. This is very important. It used to not be in front of mind when we're talking about vaccines and the cost of that, except, as you know, the last 2 years with COVID and the vaccines and the cost for that, and the controversy as to who's going to pay for ongoing vaccines. And we don't know if this is ever going to go away. Probably it's going to be part of our healthcare landscape for the vaccines. So it's very important to understand how the cost of vaccines are going to be going forward. Next slide. In 2024, this new change eliminates 5% coinsurance for Part D catastrophic coverage. That's huge because now it's going to be a smaller amount that you're going to have to pay when you get into that catastrophic phase. Expands eligibility for Part D low-income subsidy full benefits up to 100% of federal poverty level. And we're going to have a link for that for you to understand what those federal poverty levels are. And in 2024 through 2030, it limits Medicare Part D premium growth to no more than 6% per year. Now, we know every year it's been going up, but it can not go up more than 6%. So if it's $100, it's $6 per $100. So just for you to understand that. Next slide. In 2025, it adds $22,000 out-of-pocket cap in Part D and other drug benefit changes. That is not in 2023, not in 2024, but in 2025. In 2026 through 2029, it will implement negotiated prices for certain high-cost drugs. They're in the process now of looking at some of those drugs that will be included. And for a lot of you are going to be disappointed. Revlimid will probably 99.9% will not be included in that because of some of the criteria for those drugs to be negotiated. Part of that is you cannot have a biosimilar. We know Revlimid now has a biosimilar, even though the price of that is not very much lower than the actual brand name. In 2026, there will be 10 Medicare Part D drugs that will be chosen for that. In 2027, additional 15 Medicare Part D drugs will be in there, and they have pushed this rule from 2027 all the way out to 2032. So that means those things are going to go into effect, pulling more drugs up until 2032. Now, again, as we know, when there's a new administration in, a lot of times there are fights to overrun or overrule things that have been done previously. We don't know what that's going to mean. So I would encourage you to keep up with what's going on with Medicare Part D, particularly if you're going to find some changes in your treatment that's going to be even more expensive. Next slide. In 2028, there'll be additional 15 Medicare Part B and Part D drugs that will be included in this price negotiation. In 2029, there will be 20 Medicare Part B and Part D drugs. Companies that refuse to negotiate with Medicare will face a 95% tax penalty on that drug, and they are not going to want to have this tax penalty. It's very costly to those pharmaceutical companies. Next slide. So there are two policies of the Inflation Reduction Act. One requires the federal government to negotiate process prices for some high-cost drugs covered under Medicare that we just went through. These include brand name and biologic drugs without generic or biosimilar equivalents under Medicare Part D. That would include your Revlimid, unfortunately. or the retail prescription drugs, or Part B, administered by physicians. Those are among the highest spending Medicare covered drugs and are 9 or more years small molecular drugs, or 13 or more years biologicals from FDA approval are eligible for negotiation. And some of these drugs they're looking at have already been looked at for the last 8 or 9 years and have already been saying they're going to approve those small molecular drugs for price negotiation. The number of people who will see lower out-of-pocket drug costs under this provision and the amount they'll save is going to depend on several things: the number of people with Medicare who use those drugs and the price reduction achieved through the negotiation process. So a lot of this is up in the air. We probably won't know about it, just like you don't know what the changes are going to happen with Medicare, are going to be pretty much last minute. So I would keep an eye out on what's going on with that. Next slide. Relative to the prices that would have been applied in the absence of the new law, it requires drug manufacturers to pay rebates to Medicare if they increase prices, should not be processed, faster than inflation. Right now, inflation is really high for drugs used by Medicare beneficiaries. So keep an eye on what's going on with inflation, keep an eye on what drugs they're going to be approving here soon, and those will take effect in 2025. This provision could have spillover effects for people with private insurance if it results in lower process growth for drugs covered by private insurance. And here's just something I want you to be aware of. Majority of what we're talking about today is talking about Medicare Part D with those changes. And whenever there's a change on one side, there's generally a change or cries for change on the other side. So private insurance through your employers, there may be some changes in that. We don't know what those changes will be. They may start reacting to the lower prices on the Medicare side, or they may not. So I would keep an eye and keep an ear close to what's going on if you are still in private insurance and maybe changing over, hopefully to Medicare with the additional processes will have an effect that's going to reduce your out-of-pockets. Next slide. So this caps, again, the Medicare beneficiaries' out-of-pocket spending under the Medicare Part D benefit, first by eliminating the coinsurance above the catastrophic threshold in 2024, and then by adding a $2,000 cap on spending in 2025. It also limits annual increase in Part D premiums from 2024 to 2030. Capping out-of-pocket spending under Medicare Part D will be especially helpful for beneficiaries who take high-cost prescription drugs for cancers, especially those drugs who have no biosimilars and some of the newer drugs that are coming out. Now, for example, in 2020, among Part D enrollees without low-income subsidies, who will not fall under that coverage gap, average annual out-of-pocket spending for the cancer drug Revlimid was $6,200, used by 33,000 at that time beneficiaries. Next slide. The cost sharing for adult vaccines under Medicare Part D in 2023 is eliminated, and there is also improved access to adult vaccines that we were talking about earlier under Medicaid and CHIP, the Children's Health Employer Protection Program. Shingles is unfortunately common for the elderly and for people who have lower immune systems. I know myeloma is one of those. If you're taking acyclovir, it is a drug that actually helps. If you end up with shingles, it reduces the severity of it. In 2020, 4.1 million beneficiaries received a vaccine covered under Part D, including the shingles vaccine. Vaccine coverage is optional and varies by state, but I would encourage anyone who has an immune system that's compromised to talk to their healthcare team to find out if they should go in and take that vaccine for shingles, as well as the other vaccines. That's something that's very important for you to be aware of. 25 states did not cover all vaccines, and many states impose a cost-sharing requirement on adult vaccines, making them too costly for low-income Medicare beneficiaries. So be aware of these changes and find out what can be covered under your insurance plan. Next slide. In 2024, eligibility for full Part D low-income subsidies were expanded. This will impact beneficiaries with incomes up to 150% of the poverty level. If you see the link on the bottom, it says Federal Poverty Level Guidelines 2023. I would encourage you all to look at that, because this is also important, not just for this, but if you are looking for financial assistance for for your co-pays, out-of-pocket premiums, and you're going through a nonprofit like LLS, HealthTree, HealthWell, Cancer Cares, Patient Advocacy Foundation, they are going to refer to those federal poverty guidelines, as well as some of the pharmaceutical companies. So it'd be a good idea for you to keep up with those things. Those guidelines do change every year, so keep up on that as well. Beneficiaries receiving, okay, this will impact beneficiaries with low incomes up to 100% of the poverty and modest assets, and appeals the partial low income benefit that is currently in place. This is for individuals with incomes between 135% and 150% of the federal poverty level. Beneficiaries receiving partial low income benefits typically pay some portion of Part D premium and the standard deductible, 15% of coinsurance, and modest copayments for drugs above the catastrophic threshold. Beneficiaries receiving full low-income payments pay no Part D premium or deductible and only pay modest copayments for prescription drugs until they reach the catastrophic threshold, when they face no cost sharing. So it's different for those people who have higher incomes. They will have additional cost sharing, even in a catastrophic threshold. Next slide. So this benefit will benefit mostly low-income Black and Hispanic Medicare beneficiaries in particular, because they are more likely than white beneficiaries to have incomes between 135% and 150% of poverty. And I would include is for not just Black and Hispanic, it's for also rural, severely rural areas where they have low access to healthcare. A lot of people are also in that 135%, 150% poverty level, not just Black and Hispanics. Next slide. Anti-Kickback safe harbor protections. The Inflation Reduction Act includes a provision that delays the implementation of the Trump administration's drug rebate rule until 2032, rather than taking effect in 2027. So that helps. This rule would eliminate the anti-kickback safe harbor protection for prescription drug rebates negotiated between drug manufacturers and pharmacy benefit managers or health plan sponsors in Medicare Part D. This rule was estimated to increase Medicare spending and premiums paid by beneficiaries, and so that's what they're trying to eliminate and reduce and eliminate. So here's an area. I occasionally get calls from people who are now living part-time in other parts of the country, other parts of the world. And also Medicare beneficiaries or even private care plan members who live in the United States, and they know that the cost of drugs are less expensive in other countries. And they ask if it's legal, possible to get drugs, high cost drugs here in the United States from abroad. It's interesting, but the cost of our drugs, even for Revlimid and some of the things that are made in countries outside the United States that are brought here, are still less expensive to get in other countries. I mean, sometimes it's over 1,000% less expensive than in our country. So there's an ongoing debate in the government as well as states to provide additional lower cost drugs from abroad. We know that's been going on for a while. It will continue. We will review where the current law stands in terms of getting your prescribed cancer drugs from other countries. Now, you probably need to take notes on this, because if you travel a lot or you're outside the country for travel, or you spend time a lot out of the country, so you need to know how this works so you won't get caught. Can everyone hear?
Yeah.
Next slide. So can you go to Canada to get your prescriptions for a much lower cost and bring them home? Here are the current laws and regulations regarding this. If you're entering the US with FDA regulated products in personal baggage or sending products by mail or courier from abroad, the FDA has rules that governs personal importations. A personal importation is a product not for sale or distribution in the United States commerce. That means it's not FDA approved for our country. It hasn't been tested and all that. So these products may be carried in baggage or shipped by courier or international mail. For personal importation, for US citizens, in most circumstances, it's illegal to import drugs into the United States for personal use because these products have not been approved by the FDA for use and sale in the United States. Therefore, if a drug is approved for use in another country, but is an unapproved drug in the United States, it is illegal to import. So be aware of that. It may have different, you got to be aware of how they're labeled countries label things differently. It may be a drug that's approved in FDA, but it may be labeled completely different. It looks different because every country and state has the way they have to have these things labeled. So be aware of how that works as well. Next slide. So when can you import an unapproved drug to the United States? The product is not for treatment of a serious condition, and there is no known significant health risk, and this is over-the-counter drugs, not prescription drugs. The product is for the treatment of a serious condition, prescription drug products. The product is for a serious condition for which effective treatment may not be available in the United States, either through commercial or clinical means. There is no known commercialization or promotion of the product for persons living in the United States, and the product does not represent an unreasonable risk. So how do you determine all these things? Well, you need to talk to your doctor. You need to contact the FDA to get approval, or you have to have this documented if there is a question about anything you're going to be importing or bringing back to the United States. Next slide. The consumer affirms in writing that the product is for personal use. Well, we can write anything, but once you get to that border, they're going to question that, and good luck on that. The quantity is generally not more than a 3-month supply. So you must provide the name and address of the doctor licensed in the United States who is responsible for your treatment. They're going to be signing off that you have access to this product and they approve of it. You must provide evidence that the product is for the continuation of a treatment begun in a foreign country. Let's say you lived in Mexico half the time and you got an illness there and they started treating you there, but their medication is different from what we have here, and you're coming back to the United States for the following 6 years. You need to have proof that is the medication that the doctor approved for you to use in Mexico, so that you can bring that product back to the United States. Documentation, documentation, documentation. Protect yourself. Next slide. A foreign national is any person who is not a citizen or permanent resident of the United States. So if you're traveling to the United States for vacation, attending school, or travel for work, the Federal Drug Administration will allow you to bring with you your personal medications while you are in the United States. You can also ship a 90-day supply of drug products. If staying more than 90 days, additional meds can be sent to you. Documentation is required that provide evidence that the medication is being sent for your own personal use while visiting the United States. So for those people who are in school or are here doing additional work or other kind of work, that is very important for you to keep up on that, because the time to get approval, to get the documentation you need can delay your treatment. So I encourage you to make sure those things are taken care of in appropriate period of time. If you are a US citizen and live in the United States and travel to other countries, be aware of their laws regarding drug importation. Their laws change from country to country. It's going to change. And so you need to make sure you have the correct documentation for each country you're going into. Even if you have the drug in your pocket and it has your name on it, you need to have verification from your physician that the drug you're using is for your needs. And if you need to have it import more, if you're out of the country, make sure you get all the documentation you need so it won't be hung up, taken away from you at the airport or anywhere else. Next slide. If you are a patient that requires a controlled substance in your treatment and is traveling to the United States, the Drug Enforcement Agency will generally make the decision on whether controlled substances are allowed to be imported for personal use. Now you need to get on the DEA government website to find out and to call. You can also call to find out what the controlled substances are. Controlled substances may be Adderall, maybe some of those drugs that you take have been taken for years and don't think of as a controlled substance, but you need to be aware of all these things. For those controlled substances that fall under the jurisdiction of both the DEA and FDA, the two agencies will coordinate when determining the admissibility of the product, which means there's time involved whenever you get into any kind of government area for things to be approved. So make sure you give yourself appropriate time to make sure that you're not going to lose, end up with a loss of coverage or a delay in your treatment plan. Again, go to dea.gov if you have any additional questions. Next slide. In summary, this is a lot. I feel like I just went through it a lot really fast. I apologize. I'll give you time to ask questions, and I encourage you to get the slides and digest it. You may find there's going to be additional questions when you go through that and you look at your own insurance plan. I would encourage you all to do that, especially if you've picked up a new insurance plan through the Medicare this past year, and know and be aware of what's going to be going on with your treatment going forward, so that you can make changes accordingly in a timely manner. And there will be many changes coming that may reduce the cost of your prescription drugs, especially for high cost insulin and cancer drugs. They are not all going to be in effect in 2023, 2024. They will be ongoing, and there will be ongoing additions to the medications that will be approved for the negotiation of prices. So keep up on that, especially with the new drugs that are coming out for myeloma. Some of those may be included. Remember the criteria for those to be included in that negotiation price. Many of the changes will not take effect immediately, Ken, will be spread over several years. Many states as well as federal administration are doing ongoing reviews regarding the importation of drugs from other countries. Hopefully some of those things will open up to make it a lot more viable for patients to get prescriptions at a less cost. Since many myeloma patients do travel abroad, review of the importation of drug products must be adhered to stay compliant with US laws, to keep you out of jail, to keep you on your treatment plan. It's very important. Get all your documentation. More documentation is better than less, always, when it comes to those things. I know that was a lot. I felt like I just ran through it, even though when I was reading the slides on my own, it's going to take forever and ever, but gives you time to ask me some questions.
Great. Thank you so much, Diana. We really appreciate it. I know you worked really hard in the content for today, and we already have some really great questions, so I'm excited to get to them. Robert is asking, so the out-of-pocket maximum is capped at $2,000 in 2025. What is the estimated maximum out-of-pocket cost in 2024?
Okay, a lot of that's going to depend on your insurance plan. What is your insurance plan? You need to look at your Medicare insurance plan. Some of them will 2024. A lot of those things have not come out. You know, Medicare usually gives a lot of information about what your costs for your premiums and out-of-pocket costs. Those usually come out in September of the year, the changes. So we'll start seeing some of those changes in September, October of this year.
Awesome, thank you. This person is wondering about, after a stem cell transplant, insurance not wanting to cover the cost of a single shingles shot. That's a tongue twister. Because the shots were already given before the stem cell transplant, they're not authorizing a different shot, and was wondering if you know how they could get reimbursed for that or covered for those kind of shots.
Okay, so if that was something that was required by your doctor says, I want you to go in and get another shingles shot, that would be an appeal through your insurance program. That you'd have to fill out an appeal process form. A doctor's note will be helpful when you attach it to that appeal form. If it is something that your doctor says, I really think you should do that, that is an appeal process, especially if you've already had one done. A lot of times they don't replace those single shots. Shingles shots are generally one time and you go, right, as we know of. And if you're doing a second one, you know, that's why, because it's not something that's normal to do.
Yeah, sometimes they don't want you taking the shingles shots within like a certain time after your stem cell transplant as well. So just making sure with your doctor about the timing of the shingles shot. And like Diana was saying, she did a whole webinar on medical appeals. So we can make sure to get that to you guys as part of the follow-up resources that we have. We'll make sure that that medical appeals workshop that you did is available for people that might need it.
It's very interesting too. It's not just a shingles vaccine, but the COVID vaccine. You got to be aware of, if you've done stem cell transplant, CAR T, any of those things, there's going to be a timeline your doctor's going to give you as to when you can get another one of those shots, because or if you've had COVID and you want to get the latest shot, the booster shot, you need to talk to your doctor, because you need to be aware of what's going on with your treatment, and you don't want to bring something else in that's going to cause you to have any additional problems.
Thanks, Dana. Paul brings up a great and common question among the myeloma community. Wants to retire, but doesn't know what drugs he might need in the future. How can he get Medicare insurance that will cover future drug needs with Part G? He travels some for his treatment.
And that's a very complicated question because we don't know. Whenever you get a standalone drug program, any drug program, you have drugs that fall off those tiers. You have the tiers 1 through 5, and those drugs change every year through negotiations with pharmacy benefit managers. All this stuff happens, and in the future, we don't even know what drugs are going to be available to use. So it's very difficult to know what's going to be covered. I would encourage you, when you find out, if you know what drugs are coming for the following year, treatment for the following year, you can get on Medicare and find out what they currently cover. That doesn't mean it's going to change next year. So it's one of those things. A lot of people will choose Medicare plans, prescription plans, and then they forget about it. I have coverage, but you need to keep on these things every year. You need to review it and look at other options every year because drugs will fall off of plans. I can't, there's no magic bullet to say what's going to be covered next year, 2 years from now, 3 years from now. Don't know.
Yeah, but it's not common that they stop covering something that's generally widely used.
No, but the cost sharing might change.
This is where it's really helpful, I think, if you want to connect to one of our financial coaches. We'll also provide that information for you in the follow-up email, or could even type it here. If you go to our healthtree.org/myeloma/coach, you can look specifically for people that have financial expertise that are willing to talk to you for free and kind of talk you through some of these questions. Finances can be so complicated on top of an incredibly complex disease in myeloma. And so we're trying to help you the best we can. These questions are valid and common, and unfortunately don't have a solid answer.
Right.
All right. So this is Clara. She is a disabled veteran. Thank you for your service, Clara. And is saying is smoldering right now. So feels pretty covered for drugs that she might need in the future, but is wondering how to check.
That's very similar to the previous
Yeah.
question.
So what you were mentioning that they can look on the website of what drugs are currently covered. What is that website and how do they access it?
We have a medicine assistance tool link, or you can go to Medicare.gov. They have a link as well for you to look at any drugs that you have currently, or any that that are out there, whether you're using it now or not, to see if they're covered. Majority of drugs are covered, like you mentioned before, Audrey, at a certain level. Is what you're going to pay out of pocket depends on what prescription plan you have. That includes your employer plan. I don't want to just speak toward Medicare Part D, but it includes people with private insurance as well. Their prescription plans, whether you have Aetna or United Healthcare and a private insurance plan, and different levels you can get, your out-of-pockets may change, or out-of-pocket costs may be different. So there are options. There are links we have on the Coach financial resource pages where you can go in and find out about insurance. You can go to, I want to say retireaon.gov.
Oh yeah, let me
We
look.
have several links where you can call up and find out about what's covered if you're under Medicare, and you can, of course, in private insurance plans change a lot as far as the amount of pocket.
Okay.
You have to keep up with that, with what's going on with the insurance. Like I said, very rarely does a drug fall off completely. That is, when it falls off completely, generally it means it's FDA is not going to approve this drug because there's a problem with it, and you shouldn't be on it in first, anymore.
Yeah.
So I wouldn't worry about coverage. It's just what out of pocket you will be responsible for.
Yeah, and Nancy is saying go to VA formulary. VA has covered all my husband's myeloma drugs. So I'll put that. It looks like I answered it live, so you can look and you can find that information in the answered section of the questions. Or I think it's actually just what you guys see in the Q&A under answered. Okay. Great questions, everybody. Keep them up. So Fern is wondering, when does my out-of-pocket maximum take effect for Pomalyst? I don't know if we can answer that specifically, but how do they know when their out-of-pocket maximum's been reached?
Based on what on his insurance plan. He has I don't know what his insurance plans say. I don't know if he's Medicare or private pay. I don't know.
Yeah, Fern, I think this is one of the complicated parts. I mean,
He can call
insurance
his,
itself is so complicated.
yeah, he can call his insurance plan. On his card, there should be a telephone number. If it's Aetna or whoever it is, they should be able to call him and tell him what his out of pocket. It may even show it on his card. Find out what his max out of pocket is going to be. If he's concerned about if he's going to meet any of those phases, like the coverage phase Part D or going to the catastrophic phase, I mean, that we have those numbers on there.
They're referring to Medicare.
Okay, those numbers are on the slides.
Okay.
Max out of pockets, those are on the slides.
Okay, perfect. So we'll review these slides, or we'll send these slides to you for your review. Okay. Is all Medicare Part D information applicable to drugs obtained in a Medicare Advantage plan, which is not a standalone prescription plan?
I'm sorry, could you repeat that?
So basically they're asking, Dawn, I think this is what you're asking. So if it's not, forgive me, but, or maybe you can clarify, but Medicare Part D information, is it part of the Medicare Advantage plans or is it separate?
Very interesting. Medicare Part D is a standalone Medicare prescription program. You can have Medicare Part C or your Advantage plans that include prescription plan coverage within that program. So it's a complete package for Medicare Part C. Medicare Part D is a standalone Medicare prescription program. They will all work together because they're all regulated by the federal government. It's all considered Medicare.
So if you're on Medicare Advantage, do you also need to get the Medicare Part D?
Only if your Medicare Advantage does not have the Part D included in their plan. There's different types of Medicare Advantage programs.
Awesome.
So please don't think you're getting Medicare Part Advantage and you automatically have Part D. You need to make sure it has that, and also it can include dental and vision and health exercise programs, like where you go and what do you call those memberships for health plans or health clubs. Some of them have those
Gym memberships and stuff.
Thank you. Couldn't think of the name, Jen.
That's okay.
included as well. I'm sitting here looking at a treadmill and everything now. And I couldn't even think of the name.
Glenn states that Revlimid has been taken off of Humana since they are unable to get lenalidomide. It is being covered. So do you mean, Glenn, I'm not sure if you mean that Revlimid, the brand, has been taken off, but lenalidomide, because it has a generic, is being covered? If that's true, give us some clarification there. Do you know anything about that?
No, I don't. It sounds like he's asking because a lot of, generally when you go and get a prescription, you have the option to have the brand name or the generic, and your doctor's ultimately going to come down to say, I want them to be on the generic or the brand name. And if a insurer is going to say, we're not going to cover Revlimid because you have lenalidomide, but lenalidomide, just because they say that doesn't mean it's available where they are, right? So it's going to be a work between you and your doctor, because the doctor ultimately going to say, I need to have him on the brand name, because guess what? Lenalidomide may only be what you're approving, but it's not available to us.
Interesting. It just is so frustrating how complicated it is. Nancy's saying, I know people who import their routine prescriptions through a legitimate Canadian pharmacy. Has that changed, or are the rules just not enforced?
This could be off
off the record.
Right. I would love to know how they're getting them imported, depending on what drugs they're getting. Again, if these drugs are FDA approved, it's the same drug that's being used. Labeling is almost the same. It may have been already checked through when you go through importing drugs, then that may be a viable, legitimate way to do it. But if they're just going over to Canada and buying the drug and they may be just squeezing through, just be careful when you're squeezing through in that car, because somebody may stop you and they may not be in a good mood that day. And I'm just saying, you're always putting yourself at risk when you're just buying a drug in a different country and you're bringing it in our country, because they have the right to do searches, and you may have a port in your chest saying, I do have cancer, but that doesn't matter. They need to know these drugs are legitimately coming across borders.
Interesting. Tim says, great job, Diana. So you referred to a list of drugs that's being negotiated for better pricing, as you mentioned, between the government and pharma companies. How many of these, do we know what those drugs are? How many of them are typically used in myeloma treatment? Is there a place that we can be looking at what drugs they're going back and forth about?
They are looking at some now. They've come up with a couple, and they're not going to let everybody know what those drugs are, because some of those things may fall off and change, especially and they're trying to make sure there's no biosimilars coming out as well during that period of time when this stuff goes into effect. So
Right.
The closer we get to that, I will promise you, I will get a list of those things out there so everybody will know.
Okay, thank you. Appreciate it. We do have a couple more minutes. If any of you guys have continual questions, please take advantage of the resources that we have. I put one of them in the chat, which is this. I mean, I can put it in the chat now. I put it in the Q&A, but sometimes it's helpful if I put it in the chat. This is where you can look to look more about your Medicare plans and what's covered, things like that. It used to be AON and now it's a light. So it's retiree at alight.com. We'll be including that. We also have financial resources that are on our website. These are also going into the chat. These are helpful if you're looking for pharmaceutical assistance programs or other assistance programs. We have basic living expenses, childcare expenses, government assistance, things that can help you with costs that are occurring because of the myeloma in different ways. We also have, and I hope I'm not overwhelming you with resources, but lots of questions about medications in general. We do have this new medications kind of guide on our website that helps you go through what the different kind of medications are, and what how it works, how it's administered, who should take it, who shouldn't take it, common side effects commonly being tested with, just in case you have questions about the actual drugs itself.
In addition to that, some of the pharmaceutical companies have resources available for you to call and ask about the medications, and you can get a lot of information from them about, again, how medication reacts. I mean, how it reacts with other medications, things you should be aware of. If you have side effects or concerns, you can call them directly as well. And I'm in the process of updating that pharmaceutical contact list because some of those things have changed.
Thank you so much. All right. Bob has a question. Will Revlimid cost be the same regardless of which standalone Medicare Part D one has? So does the cost of Revlimid remain the same?
The Revlimid cost is not going to change. What's going to change is you got to be aware of the max out of pocket. What you're going to be concerned about is your max out of pocket for your prescriptions. That's what's going to be important.
Frustrating. I'm like normally like a pretty hopeful, excited person. And I just think that as you were saying in the beginning, our healthcare could use a lot of improvements. But I know we all know that, and there is a lot of resources to help us. And we have this information from Diana. Thank you so much. And Fern reiterated that out-of-pocket maximum in 2025 will be $2,000. Lots of 2000s thrown out there, but
it's going to help so many people.
So many people.
Yeah.
But again, it changes of administration could change that. Is that true?
You know, they try to fight everything. It could possibly change.
Okay, fingers crossed that it doesn't, because it's going to help so many people.
Right, because Trump had things was going to change in 2027, and then the Biden administration came in and pushed it out to 2032. So
Yeah. Well, I'm hopeful. I'm hopeful that
I
we
am
can
too.
find some, that we can find, I know there's been a lot of legislative work recently with trying to make things more affordable. And I think those are bipartisan things that are passed. And so I just hope we continue to see that as that goes forward.
Right.
Bob was saying it would be useful if the US had a system like NICE in Britain. I'm not familiar with that, but
I'm not either.
I would love to learn more about it. Wonderful. I would love to hear if you guys have any more questions. I'm going to go through the outro announcements, and if there's any more questions when I finish, we'll hit those as well. You can join us next month on March 7th to talk about what's the role of a financial advisor and how to choose one. And remember, as you leave the session today, we'd love for you to take 2 to 3 minutes to fill out that survey. Tell us what you liked, what we can do better next time, and what your future topic suggestions for the financial chapter are. Upcoming events, February 7th, that's tonight at 6 p.m. Pacific is our SoCal Myeloma Community Chapter. We're going to be talking about the art of personalized myeloma treatment. The 8th at 1 p.m. Eastern is our non-secretory myeloma community chapter. Dr. Faith Davies will be joining us to talk about understanding mass spectrometry and how it can be used to help test non-secretory myeloma patients. The 9th at 6:30 p.m. Eastern is our Northeast myeloma community, and we're going to be talking about mental health, how we can focus on it, on improving and taking care of our mental health. The link to sign up for any of those events and even more events I didn't mention is found at the bottom of the slide and will be included in our follow-up email. Lots of people asking for the resources as they can't see them in the chat. So let me try to pull those over. So we have this one and this one. Let's see if it's going to let me. And these are also coming in your follow-up email. So these will come to you via email shortly. As soon as we have the recording ready, we'll be able to send you these along with the recordings. So hopefully that can be helpful to you. There you go. And then Fern was wondering again, what is that out-of-pocket maximum for 2024? Unfortunately, we don't know. So that, if I understand correctly, Diana, we don't know. And we will figure that out hopefully at the ends of this year.
And they can go back into the slides. It'll say it's projecting some of the things out, and
right,
sitting in 2025, but they can look at that.
Awesome. Thank you so much. So again, those resources will be sent out to you guys. And we're here to help, and those financial coaches that I mentioned are there to help as well. So don't forget to connect with them. A special thanks again to our community event sponsors, Bristol Myers Squibb, GSK, Genentech, AbbVie, and Amgen. And a big thank you to each of you for helping us build this financial community. We're grateful for your awesome questions, and Diana for your excellent preparation. We appreciate all of you. Hope you have a great rest of your day. Thanks, everyone.